We move. This is part 2. Let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. We are continuing with part 2 of these lectures when we're discussing hypertensive disorders of pregnancy. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment. If you haven't watched the previous video, please head over there and watch the video, because this video is going to be totally Greek if you do not understand the basics, which I covered in a lot of detail in the previous video. So let's go. In the past video, we looked at gestational hypertension and we also looked at pre-eclampsia as well as the preliminaries to learn hypertensive disorders of pregnancy. In this video, we will focus mainly on eclampsia. Here's a warm-up question. A 20-year-old G1 at 36 weeks is being monitored for pre-eclampsia. She rings the bell for the nurse because she is developing a headache and feels funny. As you and the nurse enter the room, you witness the patient undergoing a tonic-clonic seizure. You secure the patient's airway and within a few minutes the seizure is over. The patient's blood pressure monitor indicates blood pressure of 160/110. Which of the following medications is recommended for the prevention of a recurrent eclamptic seizure? A. Hydralazine, B. Magnesium sulfate, C. Labetalol, D. Pitocin, E. Nifedipine. You may pause the video, scream the answer at your screen, write it down. I will give you the answer at the end of the lecture. So remember that hypertensive disorders of pregnancy are very common, like we did describe in the previous video. 4 main categories: gestational hypertension, preeclampsia and eclampsia, chronic hypertension, as well as a pregnancy, or rather preeclampsia superimposed on chronic hypertension. You may have pregnancy-induced hypertension or PIH, which actually is hypertension that develops as a direct result of a gravid state. That is with gestational hypertension, preeclampsia and eclampsia. Now, the definitions that I want you to keep in mind: a blood pressure greater than 140/90 on 2 occasions more than 4 to 6 hours apart, a diastolic blood pressure greater than 110 on 1 occasion, or a rise in the systolic blood pressure greater than 30 or a diastolic blood pressure greater than 15 from the booking blood pressure. Any one of these, you consider them as having hypertension in pregnancy. So today we're going to be looking at eclampsia. Remember that the word eclampsia comes from the Greek word meaning like a flash of lightning, because it occurs abruptly without any warning manifestations. In 80% of the disease is actually preceded by features of severe preeclampsia, which is why I say the management of severe preeclampsia in the previous video is very similar to the management of eclampsia. So we can define eclampsia as preeclampsia, which is pretty much new onset hypertension presenting after 20 weeks of gestation with significant proteinuria, complicated with generalized tonic-clonic seizures, and or coma without any other attributable cause. Remember that eclampsia may occur in patients with preeclampsia or in patients who have preeclampsia superimposed on essential hypertension or chronic nephritis. The fits usually occur more commonly in the 3rd trimester in over half of the cases. On rare occasions, they may actually occur in the early months, as we see in hydatidiform mole or trophoblastic diseases. In the antepartum period, 50% of the fits occur before labor. Most of the fits start as labor starts soon after, and at times it's actually quite impossible to differentiate this from intrapartum. 30% of the fits happen intrapartum, so this is the first time that the patient fits during labor. 20% of them actually occur postpartum. So you should actually be vigilant, especially in the first 48 hours after delivery. So fits occurring beyond 48 hours after delivery, but less than 4 weeks after delivery, we can actually accept this as late postpartum eclampsia. After they occur after puerperium, is most likely not associated with eclampsia. So more than 20% of the seizures actually occur postnatally. So women that have actually developed pre-eclampsia in the antenatal period should be monitored closely. And remember that the seizures are generalized tonic-clonic seizures. Risk factors are exactly the same. This slide is exactly the same as I discussed with pre-eclampsia. So just head over to that video and I explained this in a whole lot details. Then the pathophysiology also is quite similar to pre-eclampsia. It's only in a severe form. I did talk about the histopathological, the biochemical changes that are happening, the infiltration of the trophoblastic cells in the previous video. So if you haven't watched that, please head over there right now to watch that video because this will not make any sense to you. So in eclampsia, this is going to be due to severe cerebral vasospasms, which results in cerebral perfusion deficit as well as cerebral edema. So the causes of convulsions are going to be provoked by three things. Number one, you have anoxia, so you may have spasms of cerebral vessels leading to increased cerebral vascular resistance. You may have a fall in the cerebral oxygen consumption and anoxia. You may have cerebral edema. You may sometimes even have cerebral dysarrhythmias because of these arrhythmias, or rather dysrhythmias of the neurons, are going to be as a result of excessive release of excitatory neurotransmitters like glutamate. So there may be cortical or subcortical edema, infarction and hemorrhage due to hypoxia, ischemia or edema. You may have retinal hemorrhages, exudates, papilloedema, which are characteristic features of hypertensive encephalopathy and are rare in preeclampsia. This actually suggests that the hypertension alone is not responsible for the cerebral pathology. So what are some of the clinical features? So with exception of the rare cases, eclamptic patients actually may show some premonitory symptoms, so previous manifestations of acute fulminant preeclampsia. So in addition to those with mild and severe preeclampsia, the most significant finding is actually a seizure, an unexplained generalized tonic-clonic seizure. So it's going to be having certain stages. So the first stage is the premonitory stage, which usually lasts 30 seconds. So patients are going to become unconscious. So there may be some twitching of the muscles of the face, the tongue, the limbs. The eyeballs may actually roll and turn to one side and then they become fixed, kind of like as if they are being possessed by a demon. Then they get into the tonic stage, where there's 30 seconds also and the whole body now goes into a tonic spasm. The trunk is in this opistotonic position. The limbs are flexed, the hands are clenched, even respiration ceases, the tongue protrudes between the teeth, cyanosis may appear, and the eyeballs still are fixed. Then there's a stage of the clonic stage, which appears about 1 to 4 minutes after, where there's now voluntary muscles that are undergoing alternating contractions and relaxation. So now the twitching is also going to be starting in the face. Then this may involve one side of the extremities, but ultimately the whole body is going to get into a convulsion. Biting of the tongue usually occurs in this stage. So the breathing may be stertorous, then the blood-stained frothy sputum may be present in the mouth, cyanosis gradually disappears. Then there's a stage of coma afterwards, where there is actually, for a brief period or sometimes in others, deep coma can actually persist till they have another convulsion. So the patients actually appear confused following the fit, and they may actually fail to even remember what has happened. So rarely the coma occurs without any prior convulsions. So remember that the fits are usually multiple. They recur at varying intervals. So when it occurs in quick succession, we call this a status eclampticus. Then after the convulsions, the temperature usually rises, the pulse, the respiratory rate, and the BP also are going to rise. Urine output is markedly diminished. So some laboratory investigations we can order: a bedside clotting time, urinalysis, 24-hour urine protein collection, full blood counts, urea electrolytes, creatinine, liver function test, coagulation profile, that's your prothrombin time, INR, your activated partial thermoplastin time, serum uric acid, as well as ophthalmoscopy. So remember that the diagnosis is made clinically, where someone has an unexplained grand mal seizure occurring in a hypertensive patient with proteinuria and in a pregnancy that's greater than 20 weeks. Our differential diagnosis is going to include cerebral malaria, epilepsy, hysteria, encephalitis, meningitis, purpura cerebral thrombosis, poisoning, and sometimes intracranial tumors. Now, what's the management? Essentially, it's the same as severe preeclampsia. So generally, we want to use antihypertensives to control the BP, prophylactic and therapeutic anticonvulsant therapy, and timely delivery. So all patients must actually be referred to a hospital facility to be managed for the conditions. So you should refer them with all the maternal records and a detailed summary of the patient. Stabilized BP. Never send a patient or refer a patient without the BPs being stabilized. They may die on the way. Make sure that they're not convulsing when you're transferring them. So magnesium sulfate, that's your 4 grams IV loading dose followed by your 10 grams IM should be given. Labetalol 20 milligrams IV to control the high blood pressure, and an accompanied medical personnel or trained midwife in the ambulance must be equipped to prevent any injury or any recurrent fits and to clear the passage if this woman gets into a seizure. Diuretics are usually given if there is pulmonary edema. Then diazepam is used, the 5 milligrams slowly over 1 minute to avoid apnea and cardiac arrest. So generally, we want to admit the patients, and a senior doctor should actually see them. Involve the anesthesiology team, plus or minus the internal medicine team, as well as experienced midwives. Call for help if the patient is seizing. That's the first and most important thing. Help. Eclampsia. Then people will come and help you out. So stabilize the patient, intubate them if they need be. Remember, this is a patient that is seizing. So make sure that the airway is maintained, the breathing and the circulation is maintained. So protect the mother's airway, turn them to the side. So way back we used to insert some mouth gags, but now generally we don't do that. So turn them to the side. We aspirate any secretions. If there are any secretions, administer oxygen. You can give about 8 to 10 liters per minute by face mask. Then ventilatory support may actually be needed sometimes. So keep the saturations greater than 92%. Because remember, every time someone is seizing, their brain is becoming hypoxic. Gain venous access if you haven't. Send blood for investigations, LFTs, creatinine, full blood count, cross-match. Then, of course, prevent serious maternal injuries from the fall and prevent aspiration. So keep them in the left lateral decubitus position. Then we want to treat the hypertension. So we start them on antihypertensives. Hydralazine 5 to 10 milligrams IV every 15 to 60 minutes until the BP is less than 160 over 110. Our maximum dose is 30 milligrams IV, maintenance dose 10 milligrams per hour, or our drug of choice, labetalol, 10 to 20 milligrams IV every 10 minutes until the BP is less than 160 over 110. Maximum that you can give is 300 milligrams IV, maintenance dose of 40 milligrams per hour. Then nifedipine can be given if the BP is still greater than 160 over 110 despite giving them hydralazine, your nifedipine 10 milligrams sublingual. Methyl-dopa is going to be given otherwise once the BP is controlled, or nifedipine. Methyl-dopa 250 to 500 milligrams 3 times or 4 times a day. Nifedipine 10 to 20 milligrams twice a day. Usually we have a formulation of 20 milligrams. Then the goal is to keep it between 90 to 100 millimeters of mercury. Then if the postnatal period they still have a BP greater than 160 over 110, we can give them atenolol. Then we should administer magnesium sulfate. So there are 2 regimens, like I already alluded to in the previous video. The pre-chart regimen, which is used in our setting, the Zeuspan regimen, which is not used in our setting commonly. So in the pre-chart regimen, 4 grams IV is given over 3 to 5 minutes. This is a loading dose. Then actually give a loading dose of 14 grams. So the 4 grams is given IV, followed by 10 grams deep IM. So 5 grams in each buttock. Then after that, you're going to be giving 5 milligrams IM 4 hourly in alternating buttocks. You give this until 24 hours after the last seizure or delivery has happened, whichever one comes first. Then the intravenous regimen is giving 4 to 6 grams IV over 15 to 20 minutes and the maintenance dose of 1 to 2 grams per hour IV. You only repeat the injections if the knee-jerk response is present, because magnesium toxicity may cause absence of the deep tendon reflexes, urine output greater than 30 mils, respiratory rate greater than 12. If there is a toxicity, give calcium gluconate 1 gram over 10 minutes. And remember that the therapeutic levels of serum magnesium is 4 to 7 milliequivalents, and then we should consider this magnesium sulfate for 24 hours after the last seizure or delivery, whichever one comes first. Then for recurrent fits, we can actually give a further 2 milligrams IV bolus over 5 minutes of magnesium sulfate in the above regimens. Then we get a detailed history, should be taken from the relatives, a relevant diagnosis of eclampsia, we should make sure that this woman does not have a prior history of a seizure disease. And take note that on the risk factors, I forgot to mention that a previous primary disorder does not put the patient at risk of developing eclampsia. Then the duration of pregnancy, the number of fits, the nature of medication administered outside. Examination should be done once the patient is stable. A thorough but quick general examination, abdominal and vaginal examination is done. Catheterize the patient, monitor urine output and proteinuria. Then we should monitor the respiratory rate and blood pressure every 30 minutes, the urine output hourly. If undelivered, the uterus should be palpated regularly to detect if there's any labor. The fetal heart rate should also be auscultated immediately after the convulsion because fetal bradycardia is a common feature. Fluid balance is actually important, so fluid of choice is Ringer's lactate. Fluids should not exceed the previous 24-hour urine outputs, so plus 1,000 mils to cover for the accessible losses. So normally it should not exceed 2 liters in 24 hours. So we should infuse it at a rate of 1 ml per kg per hour. So our antibiotics can be given, so your ceftriaxone 1 gram IV BD to prevent infections, but it's not in all the cases that we do give prophylactic antibiotics. So aggressive prompt delivery is actually the key management point here, regardless of the gestational age. If the mother is in jeopardy, the fetus is in jeopardy, or both are in jeopardy. So we want to attempt a vaginal delivery with IV oxytocin infusion if the mother and the fetus become stable. So if they are above 35 weeks, we can induce them or increment labor, cover them on steroids, dexamethasone 6 milligrams IM every 12 hours for 4 doses, and we deliver them after 24 hours of the second dose if they are less than 35 weeks gestation. And we stabilize their BP to less than 160/110 in severe preeclampsia, start them on steroids, then we deliver them. Then, if the Bishop score is greater than 7, give them a vaginal delivery if there is no contraindication to vaginal delivery, otherwise a C-section delivery. So if the cervix is favorable and there is no other contraindication to vaginal delivery, surgical induction can be done with low rupture of membranes. Then if it's unfavorable, we can ripen it with a prostaglandin E2 gel or a pessary. Then of course artificial rupture of membranes can be performed. Otherwise C-section should be done. And then, of course, some of the indications for a C-section include uncontrolled fits in spite you giving them adequate treatment, unconscious patients, or poor prospect of vaginal delivery, obstetric indications like a malpresentation. So if the fits are not controlled with anticonvulsants within a reasonable period, by reasonable I mean 6 to 8 hours, then we should consider termination of the pregnancy. So delivery is the treatment irrespective of the gestational age. So we should assist the second stage of labor with vacuum or forceps, but there is a concern for an increase in the BPs. When you manage the third stage of labor, use oxytocin 10 international units, do not use egometrin, and be vigilant for PPH as well as shock. Here's a management algorithm. So someone has an eclampsia, you give them anticonvulsants, antihypertensives, plus or minus diuretics. If they're not in labor and the fits are controlled, if the baby is term, deliver them, either by induction of labor or cesarean section. If they're preterm, give them steroids to mature their lungs, then deliver them. If they're dead, we then want to induce the labor, and of course deliver them. If the fits are not controlled, within 6 to 8 hours, we deliver them. So if it's favorable to deliver them vaginally, we can induce labor and deliver them vaginally. If it's unfavorable, a C-section. If we are in labor, we perform artificial rupture of membranes, assist with forceps and the ventouse to cut the second stage of labor, then otherwise a C-section if there are other obstetric indications. Remember, for status eclampticus, thiopenton sodium 0.5 grams dissolved in 20 mils of 5% dextrose can be given intravenous slowly, and the procedure should actually be supervised by an expert anesthetist. If the procedure fails, then we use complete anesthesia, muscle relaxants, and assisted ventilation can be used. In unresponsive cases, a C-section is ideal to be done to save this patient's life. Now, what's the prognosis? It's uncertain when the convulsion occurs, but the prognosis actually depends on certain things. A long interval between the onset of the fits and the commencement of the treatment, so late referral, carries a poor prognosis. Antepartum eclampsia, specifically with long delivery interval, number of fits more than 10, coma in between the fits, a temperature greater than 38.9 with a pulse rate greater than 120, blood pressure over 400 millimeters of mercury systolic, then oliguria less than 400, with proteinuria greater than 5 grams, no response to the treatment, and jaundice. All these are poor prognosis. So if the patient actually recovers from the acute illness, she's actually likely to recover rapidly within 2 to 3 weeks. So reoccurrence in the subsequent pregnancies is uncommon, although the chance of preeclampsia is about 30%. So causes of maternal death include cardiac failure, pulmonary edema, aspiration, septic pneumonia, cerebral hemorrhage, acute renal failure, cardiopulmonary arrest, adult respiratory distress syndrome or acute respiratory distress syndrome, pulmonary embolism, postpartum shock, puerperal sepsis. Maternal complications is actually higher in antepartum eclampsia. Then causes of fetal death include prematurity, intrauterine asphyxia, effects of the anticonvulsant drugs, trauma, which is during the operative delivery. So some maternal complications grouped according to systems: CNS, cerebral edema, cerebral hemorrhage, neurological deficits, visual disturbances, which is due to retinal detachment or occipital lobe ischemia. Sometimes you may have a posterior basal ganglia brainstem lesions. These are rare. Severe complications are generally due to vasospasms, increased peripheral vascular resistance, decreased capillary venous pressure, and even pulmonary wedge pressure. This can lead to acute left ventricular failure. Hematological complications are due to a decrease in plasma volume, hemoconcentration, and an increase in blood viscosity. So this may be also inclusive of thrombocytopenia, disseminated intravascular coagulation. In the respiratory system, there may be edema due to leaky capillaries, pneumonia, which is often attributed to aspiration pneumonia, hypostatic or infective pneumonias, adult respiratory distress syndrome, and embolism. Gastrointestinal complications include hepatic damage, periportal necrosis, subcapsular hematoma. Genitourinary complications include renal failure, and other complications may include hyperpyrexia, postpartum shock, postpartum sepsis, as well as postpartum psychosis. Fetal complications include intrauterine growth restriction, which is often due to chronic placental insufficiency, intrauterine fetal death, which is due to spasms of the uterine placental circulation leading to accidental hemorrhage or acute red infarction, asphyxia, prematurity, which is due to either spontaneous preterm onset of labor or preterm induction of labor. Trauma may also be seen during operative delivery. Here's a warm-up question. A 20-year-old G1 at 36 weeks is being monitored for preeclampsia. She rings the bell for the nurse because she is developing a headache and feels funny. As you and the nurse enter the room, you witness the patient undergoing a tonic-clonic seizure. You secure the patient's airway, and within a few minutes, the seizure is over. The patient's blood pressure monitor indicates a blood pressure of 160/110. Which of the following medication is recommended for the prevention of a recurrent eclamptic seizure? A. Hydralazine? No. B. Magnesium sulfate? Yes. C. Labetalol? D. Pitocin? E. Nifedipine. So we want to give magnesium sulfate. It's used for both prophylaxis and treatment of eclamptic seizures. I really hope you understood this lecture and you enjoyed this lecture. If you did, consider subscribing. See you in the next and the final video. My name is Dr. Moses Kazevu. Until next time, bye-bye.